to a wonderful city. We met Dr. Khemkar, Dr. Mukherjee, Dr. Agrawal, and we come to know that they're doing fantastic work. So it's really great to come here. The topics of initial discussion were a little different, but we spoke to Dr. Pritam last night and we said we want to keep topics very simple and basic. And we also come to know that we are doing some shoulder work in Raipur over here. So that's good to know. So what I'm going to talk is very, very basics about rotator cuff. It's about if you have a patient walking in at a clinic with a rotator cuff tear, what you need to examine, what you need to see, and how you're going to do your decision making. So we all see all different spectrum of rotator cuff patients. So we see patients who have got partial to massive cuff tears. We have patients who come to either with a traumatic tear or degenerative tears with different age groups. Patients who come with different types of injury, time since injury, and patients with other associated pathologies. So we have all these kind of different permutations, combinations available, and how do you make a decision what is the right treatment or right procedure for a particular patient. So what's my purpose? Is that do all cuff tears require surgery? If patient has a cuff tear, all the patients can be managed arthroscopically? Why do we have a lot of cuff tear patients who are still asymptomatic? Can we predict repairability? So if you see a patient with all the factors, can you predict whether this patient with this cuff is repairable or not repairable? And why do we still have failures? Instead of doing so many things, why do we still have about 25 to 30% failure rates in rotator cuff surgeries? The first part of treatment is the conservative treatment. Conservative treatment is recommended for partial cuff tears, but what about full thickness cuff tears? To understand that, we need to identify a very basic function of rotator cuff. See, rotator cuff is a dynamic humeral depressor. The main function of rotator cuff is not abduction, but it is a humeral depressor, and the function of cuff is to balance the humerus head against the glenoid. So it has the horizontal and the longitudinal force couples. The main function of the cuff is to centralize the humerus against the glenoid and assist other shoulder muscles for the complete movement. So once we know this function, we will understand why some cuff tears are symptomatic and some are asymptomatic. We also know the bridge cable concept. So we have some patients who have got where the cable is intact, and these are the patients who will benefit maximum for surgery. So the patients who have got a balanced cuff tears, you can very well manage it conservatively if done with proper physiotherapy. We also know from this article from Yamaguchi where he compared where he did sonography of both the shoulders. So patient came to him for a symptomatic shoulder and he did a sonography of the opposite shoulder, and he found about 55% patients had some amount of partial or full thickness cuff tears, but they were symptomatic. So it's important that all cuff tears will not require surgery. Conservative treatments, well suitable for balanced cuff tears, patients who are asymptomatic with good function and minimal weakness, older age group, associated medical conditions. What is important is you need to keep a close follow-up of these patients with 3 or 6 months, and in case if they become symptomatic, you can treat them accordingly. What about symptomatic cuff tears? How do you evaluate them? Age is very important. Patients above 70 years, if have got cuff tears, there is much amount of cuff tear atrophy. Patients of less than 70 years have less amount of atrophy. Patients less than 50 are more traumatic cuff tears. With what complaints the patient has come to you, with pain, stiffness or weakness, the onset of symptoms, and for what reason he has come to you, and what are the specific clinical features, why he has taken treatment to right now. Your clinical examination consists of signs for impingement, rotator cuff specific evaluation, look for labial biceps pathology, AC joint pathology, and evidence of instability. Your cuff tear evaluation will consist of range of motion, the muscle strength evaluation, and most importantly, long lower sign. The range of motion, a simple Apple's scratch test where we do active and passive range of motion, and you check the shoulder in all range of motion. So you need to check your forward flexion, your abduction, and your rotations. This is a very simple basic test. You need to check your range of motion for any cuff pathology. Then move your attention to each individual cuff muscle. For the supraspinal test, we do something like a supine impingement test, a drop-out test, or a Jobs empty cans test. For the infraspinal test, we do an external rotation lag sign. For the subscapularis, we check for the Gerber's test and the belly press test. These are specific tests for each muscle group. And for the teres minor, we look something like Hornblower sign. So why is it important to check for the teres minor? If you have something, a Hornblower sign positive, it indicates a very severe form of cuff tear, and it indicates that you are now going to something like a pseudo-paralysis or something like an irreparable cuff tear. It's very important to examine these signs when you are going to do your cuff tear evaluation. What are you going to look in your radiology? Your X-rays, two simple views, and anterior-posterior view and outlet view. What do you check for in the X-ray? You check for the presence of rotator cuff arthropathy. What's happening to your linear joint in form of arthritis, and how is the supraspinatus fossa? Your X-rays will also give an idea what's happening to what we do is Hamada classification to look for the severity of the cuff tear arthropathies, depending upon the stage 1, which is normal, to stage 5, which has got osteonecrosis. All patients of cuff tear undergo an MRI, and you look for two important things: the anatomical factors and the functional factors. The anatomical factors, we look for the number of tendons involved and the size of the cuff tear, and functional, we look for the muscle atrophy, fatty infiltration, and what is the status of posterior inferior cuff. Your anatomic classification will consist of a partial thickness, whether you evaluate whether tear is a partial thickness cuff tear or a full thickness cuff tear. The number of tendons involved, depending upon the 4 tendons and the size of the tear. So you're going to have a small cuff tear to a large or massive cuff tear. We move our attention then to the functional evaluation of the cuff tear with MRI. So it's a Gauterius classification where we evaluate the amount of fatty infiltration in the cuff. This is very important to evaluate. So even if you go to do a cuff repair, and if you're going to have a high grades of rotator cuff, high grades of fatty infiltration, probably your cuff surgery is not going to work. So it's very important to understand what is the fatty infiltration in the cuff muscles. A simple thing to look for the muscle bulk is the tangent sign, where we take a scapular my view and we draw a tangent line on the superior aspect of the scapula, and we look for any evidence of any muscle above that. So if there is any muscle present above the tangent line, we have a good muscle. But if your muscle is going below the tangent line, it indicates a significant muscle bulk, muscle atrophy, and you have a positive tangent sign. It's also called as the occupancy ratio. So once you have seen the patient clinically, you have evaluated them X-ray wise and the MRI wise, you probably need to predict the repairability of the cuff tear. So how do you know whether your cuff tear is going to heal? You're going to see a patient of 50 years old or 70 years old with all these different findings. So how do you decide a cuff tear is going to be repairable or not repairable? For me, a patient with a little lesser age group, a traumatic cuff tear, patients whose cuff tear size is less than 3.5 centimeters, lesser number of tendons involved, chronicity of cuff tear is less than about a year for me, with Hamada's type 1 or 2, minimum arthropathy, a good muscle bulk, a lesser amount of fatty infiltration. If you have all these factors, I can say that my cuff tear is going to heal very well. But there are also other factors where there is an advanced age group, degenerative cuff tears, patients with their tears more than 3.5 centimeters, presence of a posterior inferior cuff tear or a teres or Hornblower sign positive, a very highly chronic tears, Hamada's type 3, evidence of arthropathy, positive tangent sign, and higher rates of fatty infiltration. So when I see these clinical findings on my examination, I am going to tell my patient, you have all these high risk factors and probably a tear may not be repairable. So how do you evaluate and how do you formulate your protocol if you are going to see a cuff tear? So once you see these patients, you are going to decide whether a tear is repairable or irreparable. If you have a repairable cuff tear, the next thing what you need to see is a tendon atrophy, which is a very important finding on an MRI, on your arthroscopy. So if someone has got a tendon atrophy but a repairable cuff tear, you do something like a single repair. I will come to the detail of all, but if you have got a tendon atrophy and a repairability, you do a single cuff repair. If your tendon atrophy is absent, if you have a good amount of tendon available, you do something like a double cuff repair. How do you manage your non-repairable cuff tears? Patients who have got advanced stage of osteoarthritis or pneumotic arthritis, I think so these patients straight away will require a reverse shoulder arthroplasty. Patients who have deemed non-repairable on an examination and their clinical findings, and there is no evidence of arthritis, I will counsel these patients and look for the evidence of posterior inferior cuff. If the posterior inferior cuff is present, as evidenced by presence of active external rotation and elevation, these patients I will keep a backup of a superior capsular reconstruction, and patients who has got absent cuff will require some amount of tendon transfers to get this function back. So this is my evaluation of the patients whom I am going to see with the rotator cuff test. I will just discuss one technique in small detail. A single toe cuff repair is one where you do a medialized cuff repair without putting any tension. It is very important to understand if you are going to repair your cuff under tension, your cuff is not going to work. If you have got a patient with a tendon atrophy, we do something like a SCOI technique where you do a medialized repair. Single toe repair has got its own disadvantages. Without as simple as that, we don't create a complete footprint, and there are some gap formations. A double toe cuff repair definitely is much more preferred technique, which is more stronger and more anatomical and a footprint recreation. A double toe cuff repair starts with your cuff evaluation, mobilization, and then you need to put one or two anchors medially. So when you want to put a two anchors medially, you start taking multiple bites in the cuff in a retrograde fashion, and then you complete your knots medially to have your medial anchor. This is very important. And then once you have done your medial repair, you take the free ends of all the sutures and complete your double toe cuff repair. So what are you doing is you are having multiple points of fixation medially and laterally, and you are doing a higher footprint radiation. So that's a double toe cuff repair. What is important in double toe cuff repair is your ankle placement. Your ankle placement has to be very critical, where you have a good bone available, one which is next to the articular surface and one on the below the flare of the heel. So that's where you have got, if you see this picture, that's a normal GT, that's the GT in a partial cuff tear, and that's the GT in the complete rotator cuff tear. So if you see, this bone is the weakest bone. So you need to take advantage of using anchors on this bone over here and this bone over here. Secondly, it's very important when you place your sutures. This is a small study done, which what you need to do when you want to put your suture, the suture has to be within the substance of the tendon. The more medial you go, closer to the musculo-tendinous junction, you are going to have something like a medial toe failure. So your suture has to be within the substance of the tendon. As we know, the healing of the cuff is on the bone, so it's a bone to tendon healing. It takes about 12 to 16 weeks to heal. It's very important to understand the role of tension when you're going to repair and the role of compression. So you need to follow both these principles when you're going to do your rotator cuff repair. What about patients with rotator cuff tears who has got higher amount of artery infiltration atrophy? The results are variable. We have different opinions available in literature, but it is said that about 50 or 75% patients will do well if you go to operate patients with about 3 or 4 fatty infiltration. Superior capsular reconstruction is kind of for the patients who have irreparable cuff tear but no arthritis, where we do something like a patch augmentation of the rotator cuff, and it is still we're doing it, but still it requires a lot of study to understand this technique more in advance. Reverse shoulder arthroplasty, patients with massive cuff tears, fatty infiltration and arthritis straight away will require reverse shoulder arthroplasty. Tendon transfers for irreparable cuff tears, younger patients who are ready for full rehab will benefit from tendon repairs. So what's the take-home message? When you have a patient with rotator cuff tear,
and then you will say, wow, my repair was good on scoping, my patient is not recovering. Because you have to think at collagen levels, the orientation of the fibers, the attachment of that fibers on the footprint is important. So keep this slide in your mind, because the most common tear is supra and infraspinatus. So orientation of the fibers is also important. This is how the footprint of subscap. It's totally different from supraspinatus. Supraspinatus is from anterior-posterior and mediolateral, but subscap is superior-inferior and mediolateral. And it is very broad superiorly, where the most of the tendinous portion is there, and inferiorly it's most of the muscular part. So this upper part, round one, is what the tendinous part is inserted of the supraspinatus or lesser tuberosity, and the below one is mostly the muscular part. So this was a common type of tear which has been described in literature by Lafos and many other surgeons. And if you see on routine arthroscopy, we found 50% incidence of subscap tear ranging from grade 1 to grade 4. And if the patient is more than 50 years of age, the incidence keep on increasing. So have a close look on subscap as well. A good article in Journal of Arthroscopy by my boss from Korea, Seoul, is he had done a very good cadaveric study on the facet of how the subscapularis is attached on the lesser tuberosity, and they have divided the lesser tuberosity into 4 facets, 1, 2, 3, 4. Most of the tears are in the first 2 facets, and below, if it extends, that means the muscular part is also torn. So according to that, they have classified the subscap tears. Type 1 tear is very minor tear as shown by Dr. Sergiowski right now in his surgery. Type 2 is involving the first facet, that is in the red one, which is less than 50% of subscapularis torn. Type 2B is more than 50% involvement in first facet with detachment of lateral hood or attachment which is there on laterally. Sometimes you have lateral attachment intact and only the tendon is gone. That is, it is not retracted much. But if the lateral attachment is also gone, then it retracts much medially. And type 3, it's a complete full thickness tear of subscapularis involving the first facet. And accordingly, you have type 4 and type 5. So what it says, the first facet of subscapularis tendon footprint consists of approximately 1/3 of the entire footprint, and the first 2 facets consist of 60%, which is the most common tear. Muscular portion is rarely torn. So you should know this classification and facet anatomy, because unless you know this, you won't know where to attach that cuff. So unless you know the original anatomy, you won't get it back to its original. So facet 1, facet 2, how much is the tendinous portion superior-inferiorly, mediolaterally, and as you go inferiorly, the tendinous portion decreases and the muscular portion increases. The tear pattern, subscap goes more medially and inferiorly. So it's like a reduction of a fracture which you know, then only you will get to reduce it. So you know how it is torn, it goes more medially and more inferiorly. So you need to know how to pick it from there and attach it in that direction. So clinical examination, as mentioned by sir, is very important. So if you have something like that which is quite obvious, you have a history of trauma or history of dislocation, and then there is a drop-on positive. It's like pseudo-paralysis, patient is unable to lift the hand following a trauma. So 2 things comes in my mind if patient comes to me for this kind of injury, either a massive rotator cuff tear or I am dealing with something with neurology. So keep in mind, neurological issues, don't miss it when you have a drop-on positive, don't directly jump to massive cuff tear. See clinically whether there is intact sensation on the deltoid brigadier back sign we call it. See whether patient is able to do anterior. If he is able to do anterior forward elevation, that means the anterior deltoid is working well. If they are able to do extension, posterior deltoid is working well. So you have a rough idea that you are not dealing with any neurological issue. And then of course MRI is a must. If MRI says that cuff is not that bad, go and do nerve conduction studies to rule out brachial plexus injuries. And routinely in our daily practice, how to identify and differentiate rotator cuff tear with a frozen shoulder. Ask patient to do active forward elevation. If he is unable to do but passively is able to do full, you will rule out frozen shoulder. And then you will have in mind that we are dealing something with the rotator cuff pathology. And then he is able to get it down but with pain. Because what happens when there is a long-standing rotator cuff, the humeral head migrates proximally, and that's why they are not able to do it actively, and that's why they use passive, because the head touches the acromion. And that's why they complain more of rest pain. They don't have pain while walking, or they'll complain more pain while doing some overhead activities, because the humeral head touches the acromion. And then you do all your routine tests like empty can test, full can test, which adds to your judgment clinically. You are dealing with either supraspinatus or infraspinatus or subscap. So that's an external rotation test, and then lastly you do the various tests for subscapularis, that is the belly press test. So that's the belly press test. You can see here there is a significant subscap tear because on right side the shoulder he is using his posterior deltoid to press his belly, and on the left side he is pressing it with heart, with the intact subscap. Then lift up, we are generally able to lift it up, but with subscap tear you won't be able to hold it. And then the bear hug test is more sensitive to identify them. So it's a combination of all the tests. If you will ask me which test is more specific, I think we should do all. Lift off test, belly press, Napoleon, bear hug test, then you will come to know, yeah, most of the 2 tests are positive, that means you are dealing with the one which is involved tendon. Because still clinically 40% can be missed. So it's a amalgamation of all the 4 tests, and you should know it hardly takes a minute to do all the 4 tests. Then one slide which we should maintain here is the coracoid impingement, which can be one of the precursor for subscap tear. Like we have subacromial impingement, we have coracoid impingement also. That's the importance of true AP X-ray. If you get it done properly, you can see the lateralized coracoid, which should raise your suspicion that there is subcoracoid impingement. There's a true AP view you should do. And true AP means you should see the glenoid both anterior and posterior in one plane. It should not be that you are seeing anterior and posterior borders of the glenoid. And then on MRI axial cuts to see the distance between the coracoid and the lesser tuberosity. If anything less than 6 millimeter, you should have a suspicion that patient is suffering from subcoracoid impingement. Of course, clinical judgment of tenderness, pain on the anterior shoulder should be there in mind. Imaging, as I told you, that's the true AP view of the shoulder, which says you good amount of coracoid, lateralized coracoid, the distance between coracohumeral, that's the outlet view, which shows you the morphology of the acromion, whether it's type 1, type 2, type 3, when you are dealing with supraspinatus tear. And that's another X-ray which clearly shows that there is proximal migration of the humeral head. That means there is reduction in the acromial-humeral distance. That means you are dealing something not with one cuff, might be 2 or 3, which are retracted too much, might be irreparable as well. And this patient might have some pseudoparalysis. Sometimes you may get this picture in acute massive cuff tear also, but then the history plays a role at that point. This is the normal MRI I want to show, because for subscap you should know the axial views. For supraspinatus, more in the coronal sections, and sagittal view to decide whether that is a repairable cuff or irreparable. I will let you know. So this is, if you take a coronal plane in the center of the joint, you will see this picture actually. Anteriorly is your coracoid, there is a subscap tendon, there is the bicipital groove, biceps tendon. Here is the whole muscle belly of subscap and infraspinatus. So you won't able to judge much of supraspinatus in the axial view. You need to, for axial view, this is good view for instability, Bunkards. As you can see the anterior and posterior labrum well, as well as for subscapularis. So this is partial subscap tear, and the sagittal view which I was showing is this. This is what a Y scapular Y view. All the muscles will look black on T1 or T2, I don't remember which one. But if you look completely black, that means even in the tom cuff, if the muscles are black, they are reducible and recoverable. So that's where Dr. Prasad showed that the fatty infiltration, Gotalia grading. If you see white streaks in the muscles, then you have to grade accordingly, whether it's grade 1, 2, 3, 4, and then you can pre-operatively very well can tell your patients that this cuff is repairable and this is irreparable. In this patient, you can see there is a complete subscap tear. The tendon has torn and gone medially up to the glenoid, and in the above image, you can see even the biceps tendon has dislocated anteriorly. So MRI gives you a lot more information, but provided we should know how to read that MRI. This is a bony avulsion, and this is what I was talking about. You can see the supraspinatus, infra, teres minor, all are black, but subscap has become significantly white. The strength has reduced to more than 50%. So even if you try to repair this kind of muscle or tendon, there are high chance of re-tear, because the muscle itself don't have strength. It has been replaced with fat. So the stretchability or elasticity of the muscle has reduced significantly. So pre-op MRI you can show. I do all my shoulder arthroscopy in lateral position, whether it is labrum or whether it is rotator cuff, because that's the way I have been taught and I have been trained in. So it should be blocked with hypotensive general anesthesia. Ask your anesthetist to maintain the pressure of BP around 80, 70, 80, because that will help you to reduce the bleeding and you can do your work fast. Why block? Because that helps to reduce the dose of general anesthesia and patients are really pain-free after surgery. Cuff is the surgery which is more painful after compared to non-cuff. That's the surface marking. Usually you should do in all of your patients. Mark the posterolateral angle. Put your thumb between the spine of the scapula and posterior clavicle. mark it, then put your finger on the posterior spine of the scapula, that's the lateral border of the scapula. Then you mark the anterior border of the clavicle and connect the anterolateral. So that's the way your shoulder is. Palpate the coracoid process, make a round on it, and then just palpate the AC joint and draw a line posterior to the AC joint which will divide the shoulder in anterior 1/3 and posterior 2/3. This is important for your portal placements. This usually 5 portals you need when you are dealing with rotator cuff. That's the posterior viewing portal initially. Then the posterior lateral is the portal of Wilmington, which is the viewing portal. Anterolateral is your working portal, and posterior anterolateral will be your working portal. Rarely you need nevisal portal, which is medial to the acromion, if you have to really mobilize the cuff medially, or if you are dealing with superior capsular reconstruction or other things. As I showed you this lady previously, she had a dislocation. She is 45-year-old lady with a dislocation, primary traumatic dislocation. Came to me 6 weeks saying that there is no movements in the hand. And as I showed you her MRI also, there was a significant subscap, supra as well as infraspinatus called full thickness retracted tears. Strongly suspect cuff tears in patients with primary traumatic dislocation above the age of 40 years. Don't miss them. Don't immobilize them for long. Mobilize them at the end of 10 days to 12 days, and if still they are not able to get active forward elevation or reduction, strongly suspect cuff tear before it becomes too late, because traumatic cuff retracts very fast. So this was a scopy picture. As you see, there was a complete full thickness supraspinatus, infraspinatus tear, as well as the subscap was totally peeled off from the lesser tuberosity, as you can see anterior. The important tissue which you should maintain while doing a subscap repair is this tissue, which is connecting anterior supraspinatus with the superior subscapularis, that is called as comma sign, because that tissue helps you in reduction. As in the lower video you can see the tissue, the upper one is supraspinatus and the lower one is subscap. So that tissue connecting should be maintained, because once you reduce the subscap, it significantly reduces the supraspinatus also. And see, the biceps tendon which was dislocated has got adhered to the remnant of the cuff. So don't try to remove it. Utilize that as your remnant to repair the cuff. That's the common sign important. Then comes the important step in any rotator cuff repair is the release of the rotator cuff from surrounding adhesions. Unless you release it, you won't be able to get it onto its footprint, and it should be tension-free repair. So here I am doing this release of the subscapularis muscle at its superior border in the rotator interval. This is the release of subscapularis muscle superiorly in the rotator interval, releasing the superior glenohumeral ligament, coracohumeral ligament, and some thick capsular tissue. And then you go posterior to the subscap and anterior on the glenoid neck and release the subscapularis anteriorly. See that you don't cross the tendinous portion, as you see, because if you go more inferiorly, there are likely chance you will damage the axillary nerve. So be careful, don't go below the tendinous portion. And the last thing is to release the subscap anteriorly between the coracoid and the subscapularis muscle. So I am working here inferiorly between the coracoid and the subscapularis muscle. So this is the 3-way release of the subscapularis which you need to do to have a good reduction of the tendon and a tension-free repair on the lesser tuberosity. So once you do these releases, you have an easy excursion of the subscapularis muscle, which we know now this will be a tension-free repair to its footprint. Then comes the way to prepare the footprint. Remove all the fibrous tissue on the footprint and see that you have a good bleeding surface. That's the basipital groove and lesser tuberosity. As you see, I have removed everything. You can use burr if it's a degenerative, chronic and sclerotic surface. In traumatic, usually you don't need it. And then repair it. I usually use one suture anchor, and I take a bite superior inferiorly, one bite, other bite mediolaterally to repair. So now I am rotating the shoulder, and you can see how beautifully the subscap is attached and the excursion of subscap. Once you do that, you have various techniques to repair it, and then you do your final rotator cuff repair with single row or double row. It's your preference, but definitely biomechanical advantage is there for double row and more footprint coverage is there in double row cuff repair. But literature says clinically single row and double row both works well. That's the same lady, 5 months post-op.